Good evening, and welcome to AUA's Non-Muscle Invasive Bladder Cancer Expert Guidance for Urologists live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we can continuously improve our programs. Before we get started, I would like to go over a few items so you know how to participate in today's event. Course handouts of today's presentation are available on AUA University. Please visit AUA University and follow the instructions on the slide to access the handout. Instructions will also be posted in the chat for your reference. The AUA is accredited by the ACCME and designates this live activity for a maximum of 1.5 AMA PRA Category 1 credits. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the course. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. All persons in a position to control the content of a CME activity are required to disclose to the AUA, as the ACCME accredited provider, all financial relationships with any ineligible company during the previous 24 months. Please visit AUA University to view faculty, education council, and COI workgroup disclosures. You are prohibited from using or uploading content you access through this activity into external applications, bots, software, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models, and generative AI. The AUA would like to thank Immunity Bio Incorporated, Merck & Company Incorporated, and Urogen Pharma Incorporated for providing independent educational grants in support of this webinar. Finally, I would like to introduce and extend a special thank you to our course director, Dr. John Gore, for his time, talent, and expertise in developing this program. Dr. Gore is a professor of urology at the University of Washington School of Medicine and Fred Hutchinson Cancer Center. He is program director for the University of Washington SUO Fellowship in Urologic Oncology. His clinical expertise is in urologic oncology, and his methodologic expertise is in health services research. I will now turn the course over to Dr. Gore. Welcome.
Thank you so much, and welcome everybody. The AUA is providing this education in order to update urologists on the latest advancements in non-muscle invasive bladder cancer treatment. Based on what we're trying to do, we have several learning objectives. So participating in this CM activity, we expect that you will be able to assess the risk stratification of non-muscle invasive bladder cancer to guide treatment decisions, employ diagnostic techniques for non-muscle invasive bladder cancer, including cystoscopy, cytology, biomarkers, and other advanced imaging modalities. Tailor the treatment strategies that you choose based on individual patient characteristics, including their tumor biology, in order to highlight the potential impact of personalized medicine in non-muscle invasive bladder cancer. Identify some of the new and emerging therapies for non-muscle invasive bladder cancer, and properly manage adverse events associated with non-muscle invasive bladder cancer treatment. At this point, I would like to introduce our panelists. It's my pleasure to introduce three subject matter experts engaged in bladder cancer care. Dr. Peter Black is the Executive Director of the Vancouver Prostate Center. He's Professor and Vice Chair of the Department of Urology at the University of British Columbia. He has a clinical subspecialty interest in the treatment of cancers, especially bladder cancer, and leads a translational bladder cancer research program focused on resistance to chemotherapy and immunotherapy and the development of novel targeted therapies to treat that resistance. Dr. Black is the surgical oncology co-chair of the NCI Bladder Cancer Task Force, chair of the Canadian Bladder Cancer Research Network, president of the International Bladder Cancer Network, and vice president of education for the Canadian Urological Association. He is also the editor-in-chief of the Société Internationale de Urologie Journal. Welcome, Dr. Black. Dr. Pauline Philippou is a urologic oncologist at the Permanente Medical Group in Northern California and an affiliated clinical assistant professor in the Department of Urology at Stanford University. She completed her urology residency at the University of North Carolina in Chapel Hill and Society of Urologic Oncology Fellowship at the University of Washington in Seattle, Washington, where she was a Urology Care Foundation scholar studying palliative care in urology. Thank you, Dr. Philippou. And Dr. Vadim Koshkin is an associate professor and genitourinary medical oncologist at University of California, San Francisco, where he co-leads the bladder cancer clinical program in medical oncology. His research interests are focused on clinical trials, targeted agents, biomarkers in bladder cancer, as well as imaging and radioligand therapies in bladder and prostate cancer. He is co-leading the Urothelial Cancer Network to investigate therapeutic experiences, or UNITE study, which is a large multi-institutional retrospective study of patients with advanced urothelial cancer treated with novel targeted agents. Thank you very much, Dr. Koshkin. So let's get started. Our first topic is risk stratification of non-muscle invasive bladder cancer. A 69-year-old woman undergoes TURBT for a 2.5 centimeter right lateral wall papillary tumor. Pathology reveals non-invasive low-grade papillary urothelial cell carcinoma. Dr. Black, what is the importance of using a risk stratification scheme in caring for non-muscle invasive bladder cancer patients?
Yeah, first of all, thank you, Dr. Gore, for the invitation to take part and the kind introduction. I think that risk stratification is really the foundation of everything that we do for managing patients with non-muscle invasive bladder cancer. And whenever I speak about it, I always say, to the urologic audience, if you remember one thing, remember risk stratification and how it impacts treatment. I think, I immediately in my head put a patient in whichever box and think, okay, low risk gets surveillance, intermediate risk gets, chemo BCG for a year, high risk gets BCG for 3 years. So it really determines immediate management and then also the ongoing surveillance, the frequency of cystoscopy and cytology. So super important.
Dr. Philippou, do you mind walking us through the AUA risk stratification for non-muscle invasive bladder cancer, and especially if there are any differences between the AUA risk categorization and the EAU risk categorization?
Sure. So the AUA risk stratification is listed here. The AUA breaks non-muscle invasive bladder cancer into low, intermediate, and high risk. I think it's easiest to memorize the low and high risk and then know that intermediate risk falls into everything in between. So for the low risk group, you've got pun lump, papillary urothelial neoplasm with low malignant potential. And then you've got your low grade non-invasive, so TA solitary tumors that are generally 3 centimeters or less. And then on the other end of the spectrum, you have high risk disease. So this is your high grade CIS, T1 or a TA non-invasive that's greater than 3 centimeters or multifocal. And then a subset of that group is this very high risk features, which the EAU actually splits off into its own category. And that includes patients that are BCG unresponsive, which we'll talk about the definition of, variant histologies, so squamous, plasmacytoid, glandular, a whole host of different ones. And then high risk pathologic characteristics, so lymphovascular invasion and then prostatic urethral invasion. And intermediate risk is kind of everybody in between. And it's a really broad category. The EAU has some slight differences. They include in their risk stratification age. So patients over 70, it's considered an additional risk factor that bumps up some patients into a higher risk category. They consider low-grade solitary T1 is actually low-risk disease, where the AUA, that falls into the intermediate risk category. And then you use the additional risk factors that they determine as, age over 70, multiple tumors, or tumors over 3 centimeters to further risk stratify people within each category. So for example, a low-grade TA multifocal tumor over 3 centimeters in a patient over 70 actually becomes high-risk disease. So little slight nuance differences. And then the high-risk separate category, which goes into treatment. So this patient in either AUA or EAU risk stratification is considered a low-risk non-muscle invasive bladder cancer patient.
Dr. Black, which risk category or patient clinical category is the biggest challenge for management in your practice?
I think the intermediate risk patients are often the gray area. I think the definition tells you alone. We define low risk relatively precisely and high risk precisely, and then intermediate risk is this mishmash. And so I think there's a real risk of over-treating some patients, patients who have very occasional, small, solitary, low-grade recurrences. Yet some patients are actually higher risk. We think of intermediate risk as really not having that high a risk of progression, but some patients in there do. So I think that's the hardest to sort out. I think from a treatment point of view, of course, the very high risk patients are the most likely to have a bad outcome, most likely to develop metastases or even die of bladder cancer. So we have to be vigilant there. And I think that another key question is just when to do cystectomy, and that's something we always struggle with.
Absolutely. Similarly, high potential to overtreat, high potential to undertreat.
Yeah.
Moving on. We're going to focus on non-muscle invasive bladder cancer diagnostic techniques. So a 72-year-old man presents to your clinic with a CT performed for gross hematuria, which shows a bladder mass. On office cystoscopy, you see the tumor shown. Dr. Philippou, other than your cystoscopy, are you employing other diagnostic tools in the evaluation of this patient?
I am. So I think the first one that comes to mind is cytology. Every patient that has gross hematuria is getting either a voided or a washing cytology, usually done at the time of the cystoscopy, which can sometimes help kind of determine a little bit the risk of tumor upfront before getting pathologic analysis due to the high specificity of cytology for high-grade disease. And it can kind of sometimes help with counseling, anticipatory counseling of patients before they're going for TURBT of what this is, what we likely are expecting to find, and what the, treatment course and further surgical course after initial TURBT is going to be. So cytology is definitely helpful. Upper tract imaging, so making sure usually with a CT urogram or delayed phase CT scan of the abdomen and pelvis, to clear the upper tracts, look for renal masses, look for upper tract filling defects, using an MRI if CT isn't able to be performed because of kidney function issues or allergies to iodide contrast. MRI can be helpful. And then in the clinic, using narrowband imaging, most cystoscopy cameras are able to toggle back and forth to narrowband imaging, which can sometimes help detect smaller satellite lesions, or maybe not for this tumor, but smaller tumors help you better, counsel the patient about how much resection is going to have to happen, or if it's going to be more of a multifocal thing or a single location swipe. So those things can all be helpful at the time of the cystoscopy.
Dr. Black, do you incorporate any other urinary tests besides cytology in your workup for non-muscle invasive bladder cancer? And as you consider new biomarkers that you think that you want to incorporate into your practice, are there any parameters that you're looking for as you evaluate those? Things like sensitivity, specificity, negative predictive value, whether they're sort of validated against a clinical outcome like progression. What are your thoughts about that?
Yeah. I think I'm a bit of a urine marker nihilist, and it's partly because we don't have a lot of access in my region to the biomarkers. But I think there are a lot of really encouraging biomarkers out there, urine markers especially. And I think we've come a long way from single proteins to for example, panels of RNA or DNA changes. But I think the key limitation is that the studies don't really tell us if it's safe or not to change practice based on biomarkers. So can we avoid cystoscopy in patients who present with micro or gross hematuria? Can we avoid cystoscopy in patients who are being followed for non-muscle invasive disease? And we don't really have good data on that. I think that in the diagnostic setting, so that patient with hematuria, I think we already do way too many cystoscopies. And you know, if you think that 95% of patients who we evaluate are not going to have a tumor or a bladder malignancy, then the negative predictive value of doing nothing is already 95%. And the biomarker that ups that to 96% really isn't helping us that much. So I don't use any of the markers. I think there are some good ones. I won't name any by name just so I'm not biased. But I think the negative predictive value is the key parameter that we need to know. If the biomarker is negative, are we comfortable that the patient doesn't have cancer? We may have the, you know, if the positive predictive value is not great, we will end up doing a few more cystoscopies than we need to. But right now, the default is cystoscopy in everybody. So that's already a benefit.
Are there any biomarkers that are kind of on the horizon that we should be aware of?
Yeah, well, I think there's a lot of hype, shall we say, around urine tumor DNA. So isolating DNA from urine and then sequencing it, and you can, you know, really get an idea of the molecular makeup of the bladder tumor, which may or may not, well, I mean, sure, it certainly does have some impact on prognosis and response to treatment, although we haven't necessarily characterized that very well yet. And of course, DNA sequencing is just getting, you know, easier and less expensive. So these tests can be refined over time, that you're able to do more and more. So I think that urine tumor DNA will hopefully have the same sort of positive negative aspect, is there cancer, is there not cancer, but will also characterize the cancer in a way that it helps guide treatment. Should the patient get BCG, should they get cystectomy, whatever else it might be. Another, you know, low-hanging fruit, of course, is to detect FGFR alterations in urine, FGFR3 alterations, so that you could potentially treat with, you know, an intravesical FGFR inhibitor whenever that becomes available.
Fantastic. You know, Dr. Philippou, you had mentioned advanced imaging techniques and things like MRI. You were talking about MRI in cases where patients have an exception to CT. Are you using MRI more electively for maybe greater specificity and the ability of MRI to clinically stage some of these patients, or what other advanced imaging techniques have you been using?
Yeah, not too regularly. I think there's a lot of in certain situations, like inter-observer variability of how MRIs are read, and I think it's hard to sometimes obtain them just from a access perspective. There are certain times where it's helpful. For example, if your manual exam doesn't correlate well with what the pathology showed, or you have concern for a much more invasive tumor, an MRI can help delineate that for a surgical planning perspective. I've used PET a couple of times on non-muscle invasive patients who, say they have lymphadenopathy on cross-sectional imaging, but T1 disease, no muscle invasion, trying to get a sense of if this is something else, if this is real, is it inflammatory? But I think it's more of the, it's not so much the norm. I think there's some spaces where MRI could potentially be helpful with staging, the VIRAD system of classification to try to determine muscle invasion with an MRI is being looked at, but not in prime time, so to speak, yet, I think, at least in where I practice. And the situations where it could be helpful, like say if you're looking into staging a diverticula or full of tumor, or you're wanting to see if there's UO involvement of tumor, it's really hard to get a good read. There's a lot of variability in how these MRIs are read. So not turning to it immediately for sure.
How do you incorporate imaging in follow-up or when patients have a recurrence among those that recur?
Yeah, so regular surveillance of high-risk non-muscle invasive bladder cancer includes every 1 to 2 year CT scan of the upper tract. So that's important to remember. And then when someone recurs, I also tend to look at the upper tracts. I've found a couple of upper tract tumors that have been seeding bladder tumors that way. So important to look at the upper tracts when you have a recurrence.
Thank you very much. We're going to shift gears a little bit as we think about tailoring some of our treatment strategies to individual patient characteristics. So let's say after TURBT or carcinoma in situ, for which a patient receives induction BCG, the 6-month surveillance evaluation demonstrates recurrent carcinoma in situ. Dr. Koshkin, what is BCG unresponsive non-muscle invasive bladder cancer?
Yeah, happy to discuss this important topic as well. And thank you for the invitation to participate in this course. BCG unresponsive non-muscle invasive bladder cancer is broadly defined as recurrence or progression during or shortly following BCG therapy. But of course, there are more specific definitions of this. And this presumes that a patient has actually has had adequate BCG. So many patients for whom BCG has actually failed may simply not have received enough. So there are certain guidelines available. There's also FDA guidance, and I think that's kind of largely summarized in this slide here. So this is used to guide some of the clinical trial inclusion criteria. And so for the purposes of this guidance, BCG unresponsive disease is defined as one of 3, and that's highlighted basically in red here in the slide. One option is persistent or recurrent carcinoma in situ alone, or actually with Ta/T1 disease within 12 months, so less than or equal to 12 months after last dose of BCG or of completing basically adequate BCG therapy. Also defined as BCG unresponsive is recurrent high-grade Ta or T1 disease within 6 months of completion of adequate BCG therapy or last dose of BCG. And then finally, T1 high-grade disease at the time of the first evaluation, so usually 3 months after start of BCG, qualifies as BCG unresponsive as well. These are some of the criteria, again, that have been used in some of the clinical trials that led to approvals of agents such as Keynote 057, for instance. And then I'll also highlight that, again, the definition of what is considered adequate BCG therapy is also important. And so here, to be considered as having received basically adequate BCG therapy, a patient has to have at least 5 or 6 doses of the initial induction, plus either at least 2 of 3 doses of maintenance therapy, or again, 5 or 6 doses of initial induction and at least 2 of 6 doses of a second induction course. So in those circumstances, then these recurrences would qualify as BCG unresponsive.
Thank you very much for that. Systemic therapy is increasingly being used or evaluated in non-muscle invasive bladder cancer, either alone or in combination with intravesical treatments. Are there any strategies that you use to personalize selection for therapies like pembrolizumab?
Yeah, so I will say, I often see these patients actually after they've already seen my urology colleagues. And so after some of the intravesical options have already been offered to them and discussed with them. And so oftentimes, actually, when I see these patients, they're, of course, there to see me as a medical oncologist for systemic pembrolizumab. But I often actually would first encourage them to consider some of the additional intravesical therapies that are now available. Unless, of course, there are, specific contraindications, like that they may not, be able to tolerate such therapy well, or, if therapies are not available, of course. I often actually see pembro as, one of the options of last resort, again, prior to radical cystectomy, or for patients who would actually be ineligible for radical cystectomy. But it is an important option, and certainly, considering which patients are even eligible for it, is also very important. So not everyone will qualify for systemic pembrolizumab. So patients with rheumatologic conditions, such as those on immunosuppression, on high-dose steroids, it may not be a great option for them. And that's, especially considering that, you weigh the benefits versus risks of this approach. And really, you see here that really durable responses with systemic pembro, you see in about 20% of patients. So, in someone where for whom a patient for whom pembro would be relatively contraindicated, I don't know if I would go for this, and potentially would consider a non-systemic option if it's available. And then, of course, there are absolute contraindications to immune checkpoint inhibitors, systemic immune checkpoint inhibitors, such as pembro as well. And these, of course, include organ transplant patients, patients with, I would say, rheumatologic disorders involving the central nervous system. There, I probably just wouldn't even really consider this. But, for many patients, again, it is an important option. And, over the past several years, of course, we've had this as an option in clinic.
Dr. Black, thinking about individual patient characteristics, tumor characteristics, and some of the ancillary tests that you mentioned, how do you integrate these to decide on which treatments you want to pursue for non-muscle invasive bladder cancer patients?
You mean specifically BCG unresponsive, or before that?
Even before that, but oftentimes it's more relevant to BCG unresponsive patients.
Yeah. Well, I think that I agree with Vadim that pembro, since we now have other options available that are intravesical, that pembrolizumab has moved to sort of the last option before cystectomy, or for those who truly are not cystectomy eligible or willing. But I think there's also a group of patients who really just do not tolerate anything intravesically. Their bladders are beat up after so many rounds of BCG and resections and single dose chemo, et cetera, and they can't hold the intravesical agents. And so that's a subset of patients where you might consider pembrolizumab sooner. I think for the most part, I will offer patients one round of second line therapy after, when they're BCG unresponsive, and then really push for cystectomy after that, because that's when I start worrying about progression. And so that's my general rule. And I think if a patient is younger and fitter, they have more to lose, and I'm particularly aggressive in pushing for that. And of course, there are older, frailer patients who are really not going to do cystectomy, and then I'm more likely to go with another line of intravesical therapy and draw it out as much as possible. I think we tend to think of T1 tumors in this setting as being higher risk for progression, although I'm not 100% sure that the data bears that out completely, because even BCG unresponsive CIS can behave very poorly eventually. So yeah, I think in the pre-BCG unresponsive setting, I'm thinking about a lot more things, like when to use single dose chemo, when to use blue light cystoscopy, and I'll use different parameters there, but that's a different question than in this setting.
Going back upstream, like you mentioned, Dr. Philippou, how has your practice been affected by periodic BCG shortages?
Yeah, quite a bit. I feel like all of our practices have been, and it's a week by week thing, just based on supply and what we have access to. And so the treatment decisions we're making have to adjust accordingly, unfortunately. But there's some things that you can safely do, when there is a shortage or a dire shortage, depending on what your access is like. So prioritizing high risk patients, I think, is the main one, making sure that those are the patients that are getting BCG, and their BCG isn't being given to patients with low risk disease, for example. It's an easy fix. Reducing the dose, so maintenance dosing going down to 1/3 has shown equivalent efficacy in terms of the effect of maintenance therapy. For us, we unfortunately are only able to give 1 year of maintenance therapy. We can't do all 3, even for high risk patients. So doing that is kind of prioritizing the early maintenance period in a high risk patient. And then, considering induction chemotherapy. So as Dr. Black mentioned earlier, the intermediate risk patients have a really big category, and it feels almost too much to give a low grade TA, a little bit larger tumor, a whopping dose of BCG, when you could give induction gemcitabine and probably have it be a little bit more effective for that specific disease state. So tailoring therapies based on what you have available, and then considering alternative inductions for high risk disease. So if someone has BCG unresponsive disease, instead of trying a second course of BCG, switching to gemdosi or another agent sooner. Always you can try to mitigate issues with access.
Yeah. You mentioned gemdosi, which I think we hear about a lot. Dr. Black, are you using a lot of combination intravesical chemotherapy in your practice?
Yeah, I think, gemcitabine docetaxel, you're showing the data here. This is from a multi-center retrospective series. And so it's not the greatest data, but it appears to work well in this, in this type of report, at least. And so this has actually become our standard of care as the next line therapy in BCG unresponsive patients, recognizing that the new drugs haven't actually entered the Canadian market yet. So that might be different if you have other things available. But it's low cost. It's generally well tolerated, and it appears to work well. I would say my own experience definitely validates this retrospective report.
Dr. Philippou, nadofaragene and nogapendecan have been recently approved for use in non-muscle invasive bladder cancer. What are their indications for use, and how have you been integrating these therapies into your practice? How do you decide between these newer therapies and some of the existing options like combination gemcitabine docetaxel?
Yeah, good question. So these drugs are pretty amazing. I mean, it's really exciting to see what's being put on the market and how it's working, and the different kind of modalities of how people are trying to tackle this problem of getting, medicine into the bladder cancer in a space that's relatively protected. So, nadofaragene, it was approved in 2022, and this is the results from the kind of phase 3 clinical trial that led to its approval. It's a gene therapy, which is super exciting. It basically means that they took an attenuated adenovirus and then infuse it into the bladder, and that transfuses an interferon gene into tumor cells and creates this kind of bladder inflammatory response. And the indication that it's for is mainly BCG unresponsive CIS, with or without papillary tumors, high-grade TA or T1, and they did have a papillary-only cohort, so you can give it if CIS is not present. And it's only once every 3 months, which patients, I'm sure, really like, only having to get an installation every 3 months. In terms of when I use it, so I work within a value care based organization, and so we unfortunately don't have access to this yet. I think we're still investigating the value and kind of creating the protocols to be able to give it. So if it's something that I do think is appropriate for a patient, I refer usually as part of a clinical trial that's available, or to a nearby center that has it. But I think of it as, for non-muscle invasive bladder cancer, BCG being the kind of ultimate beginning step, gemdosi if that doesn't work, and then these other therapies, nadofaragene, and then nogapendican, which we'll talk about next, as being kind of the third tier if cystectomy is not possible or not desired, or just for whatever reason can't be done. This one, nogapendican, also known as N803, is a IL-15 superagonist that's given with BCG. So you have to be able to have access to BCG to be able to give it. And it essentially elicits an innate immune response. So it tries to get the immune system to remember and memory cells activated to kill the bladder cancer. And also in the same space of BCG unresponsive CIS with or without papillary tumors. And this was recently approved, but I don't even know access-wise if it's able to be given off of trial. We don't have access to this currently. But again, falls into that category of like intravesical therapies when cystectomy or pembro isn't appropriate.
Thank you very much. Dr. Black, it seems like this is an area of a lot of research investment. So there are other therapies that may be pending regulatory approval soon. Can you tell us a little bit about the Bond 003 trial or the Sunrise 1 trial of TAR-200 as emerging therapies that we should probably be aware of?
Yeah. I mean, it's exciting times with this real investment in the BCG unresponsive setting. And I think it's important to recognize that these trials are primarily targeting patients with CIS, and their primary endpoint is to demonstrate clearance of the CIS. The presumption is that you can resect a papillary tumor, but you can't resect all of CIS. So the drugs are measuring complete response rates, and then very importantly, you want to see the durability of that response rate beyond just 3 to 6 months. And one of the really important things that happened with N803 is that they allowed reinduction, and then their results were clearly better than prior results, and they sort of set a new bar, even though it was a different trial design, so it was a little bit different, but. And then these subsequent trials have been designed similarly. So with TAR-200 and cretostimogene, they also allow, well, TAR-200 is different, but cretostimogene also allows reinduction. But so I think everyone's familiar with TAR-200. There's a lot of hype around TAR-200. I see some of these, I would say TAR-200, cretostimogene, and N803 are very similar in efficacy as far as we can tell. Always hard to compare, but TAR-200 is the pretzel device that's deployed into the bladder, and it elutes gemcitabine over 3 weeks. You have to then take it out and put in another one, and you do that repeatedly so that patient has a chronic exposure to the gemcitabine over the first, I guess, 120 days of the trial. And so in again, single arm BCG unresponsive 85 patients, the red bar in the middle is the key that this TAR-200 device alone led to an 83.5 overall complete response rate, which is the highest we've seen to date. The trial is not completely, you see this references from the European medical oncology meeting in September, I think it was. And so it's very recent results, but it's not yet the mature and final results with longer follow-up, but it's certainly very encouraging. And it reaches a bar, and then the durability of response you see in the table. So in the middle column, the estimated 12-month complete response rate is 57%. So that also is setting a new bar that you can, if you treat these patients, that you can actually expect almost 60% of them to be disease-free after a year. With pembro, that number is 20% or 19%. So it is potentially a major advance, which I would say is, it's similar again to N803. I don't want to overemphasize one drug over the other. what you also see on this slide is that they had multiple groups in this trial, which is interesting because the first trial where we actually have comparative groups, and even though they're sort of evaluated separately, but citrilimab is an immunotherapy, so similar to pembrolizumab. And so there's the TAR-200 plus the citrilimab, and there's the citrilimab alone in the two black bars. And interestingly, the combination didn't do as well as TAR-200 alone. Citrilimab did similarly to Keynote 57 and the other trials similar to that. But it adds the toxicity and potentially expense of the immune therapy. So that is something that we've sort of now dropped, and we're just excited about TAR-200 alone for the time being.
And you know, pursuant to your comment about kind of waiting for more mature data, you can see the median follow-up in the TAR-200 monotherapy cohort is just 9.2 months. So definitely awaiting more mature data. Yeah.
Yeah, especially for that key durability question. And then, yeah, so this is cretostimogene, which is an oncolytic virus. So it's an adenovirus. Nadofaragene is also an adenovirus, but nadofaragene introduces the gene to make interferon, which then clears the cancer. Cretostimogene actually is a virus that gets into the cancer cells. It only replicates in cells that have defective signaling, so related to the RB pathway, and then it actually kills those cells. So they rupture and release virus to go on to the next cell, like we learned back in undergrad or whenever we learned that for viral infections. So it has a similar trial design again, just cretostimogene alone in this case, and it has a 75% CR rate, and of those 75% who respond, 83% of them are still disease-free after a year. So not 83% of everybody, but 83 of the 75%. So still very good, similar to the TAR-200. And the really interesting thing here, I think, compared to the competition, is the last point on this slide, that there were no grade 3 or greater adverse events.
So it seems to be very well tolerated.
Yeah.
You know, those were the two main things we talked about. Are there other emerging therapies that we should be aware of?
There are, and there are a couple that we've seen some early results on, and then of course there are others that are just getting going. One is there's a photodynamic therapy that the company Theralase is doing. They put a photosensitizer into the bladder an hour before rolling into the OR, and then applying a specific laser light in the lumen of the bladder under anesthesia. And that just, the cells that have taken up the sensitizer are then killed, and the sensitizer targets the transferrin receptor, which is upregulated in cancer cells. So it is somewhat specific to cancer. And results of that trial have been presented, interim results, preliminary results have been presented at the AUA, and also looks encouraging. Does have some local toxicity in the bladder for sure. And another one to highlight maybe is the enGene EG70 drug, which is also a gene therapy like nadofaragene, but it's not viral based. They're actually putting in a plasmid with a solution that helps it get taken up into the bladder cells, and this plasmid carries the genes to express RIG1 agonists and also interleukin 12. So it produces interleukin 12, and basically it impacts the immune surveillance of tumors and leads to cell death that way. And so we saw some phase 1 results from that looked encouraging, and they're now doing a big phase 2 trial, the Legend trial, in BCG unresponsive CIS. So we'll really look forward to that. And that's, we have 3 with 2 being submitted to the FDA next year, and then probably these 2 potentially after that. We're going to have really a a wealth of treatments to offer our patients.
Yeah, I mean, I think one of the things that we have struggled in non-muscle invasive bladder cancer for so long is options. And so it seems like we have emerging options. You had mentioned earlier in discussing risk stratification the challenges of managing intermediate risk non-muscle invasive bladder cancer. And we also maybe have some emerging options there, including an installational hydrogel from Urogen from the UGN Envision trial that showed some benefit in intermediate risk patients. Moving on to the final segment. So let's say we have a 74-year-old man on pembrolizumab for BCG unresponsive CIS who endorses watery diarrhea with 8 stools above baseline, crampy abdominal pain after just his 3rd infusion. As we talk about next steps, Dr. Koshkin, what should a urologist know about immune-related adverse events that commonly occur with immune checkpoint inhibitors, and potentially, those more severe immune-related adverse events that we should be concerned about?
Yeah, so this is a very important question, of course, a critical question, especially as we are using these agents, including systemic, immune checkpoint inhibitors, more and more in settings where maybe we haven't previously been using them as much, where we're less accustomed to using them. And again, pembrolizumab, as we described earlier, has durable efficacy for maybe about 20% of patients. So, certainly some patients benefit from it. And it's interesting that, across the board, whether in the metastatic space, perioperative space, that's sort of about the percentage of patients that have, significant benefit with Pembro. So Pembro monotherapy in the metastatic setting, for instance, is about a 20-25% response rate. And so the efficacy seems to be consistent, but then, the key here is that the side effects also can be consistent, right? So across all the pembrolizumab studies, probably about 15% of patients or so on average have grade 3 or greater adverse events, right? And so as we use this more and more in the non-muscle invasive setting, especially as other immune checkpoint inhibitors become available that are actually injectable. And so their use potentially will spread and will be easier to use, right, and administer. We really have to be aware of these and really pay attention to some of these adverse events. So while these drugs are generally, that is immune checkpoint inhibitors, are generally better tolerated than a lot of other systemic therapies that we give, right, like chemotherapy or antibody drug conjugates, for some patients, things really can go wrong. And that's again, always an important thing to highlight. And so these side effects should both be expected to some extent for even a minority of patients, and we should be prepared to manage them, right? Or whoever is administering these drugs should be prepared to manage them. So, I mean, generally, the data we see again on the slide here is pretty consistent with the type of adverse events we expect with single agent Pembro. Most events will be low grade, but a few will be higher grade and potentially even significant. But then, as you see here in the chart, common adverse events are diarrhea, fatigue, pruritus, and also rashes. And that's really generally what I counsel my patients with who are starting on checkpoint inhibitors to expect probably in general milder side effects like fatigue, rashes, arthralgias are pretty common. But in rare situations, we really should be aware of and pretty vigilant of more significant adverse events. And so what I tell patients is these therapies, they can cause inflammation really anywhere in your body and can really cause side effects in almost any organ, right? The other, common side effect we see are actually effect on the thyroid gland. So initially hyperthyroidism, that's then followed by a hypothyroidism, an underactive thyroid, which you also see in the table here. But then the two potentially severe adverse events I highlight are also pneumonitis and colitis, as well as like symptoms that patients can expect. So the patient in in the stem on the previous slide, potentially has a grade 3 colitis, right, that we that we need to manage. And so, that is something I definitely give patients guidance on. Pneumonitis is, also a rare adverse event, but potentially, again, very, scary and concerning. So again, I counsel patients to watch out for any new, cough or shortness of breath, and that should really trigger an immediate, sort of reaching out to the healthcare provider in the clinic that's prescribing this medication, and then really any other organ can be affected, and we see effects on the kidneys with nephritis. That's pretty rare, usually a later side effect, but certainly monitor the kidney function, and patients getting these drugs can get autoimmune hepatitis that's checkpoint inhibitor induced, and so LFTs can go up, and so we monitor that pretty closely, as well as more rare but significant adverse events. So new autoimmune diabetes, in very rare situations, CNS side effects as well. So while all these really potentially pretty severe side effects are pretty rare, right? And so here, even in a clinical trial like this, like Keynote-057, not a lot of these were seen. But as we treat more and more of these in practice, and also in practice, patients are usually sicker, often a lot less fit than the patients that make it into these clinical trials. They're potentially more vulnerable, actually, to some of these more significant adverse events as well. So these are some of these rare but significant adverse events. I have seen in these patients where it's potentially a bit more than they bargained for, in the treatment of, non-muscle invasive disease, where, they also have other options with potentially fewer systemic effects. So I think these are some of this is some of the counseling we provide, and some of the things that, hopefully, the patients and providers will look out for when, administering a drug like pembrolizumab.
Thank you very much for that really thorough outlining of kind of the various things that we need to be afraid of or aware of in patients getting pembrolizumab or whatever new immune checkpoint inhibitors or immunotherapy agents are going to be improved in this clinical space. So let's say, Dr. Philippou, you have a 77-year-old man getting induction BCG for T1 high-grade non-muscle invasive bladder cancer. It seems like his treatments are getting a little bit harder to tolerate, and on his third treatment, he was only able to hold it for 45 minutes. And so now he's having worsening bladder pain, some urgency, some frequency with each treatment. How do you manage bothersome urinary symptoms like bladder pain or frequency or urgency that commonly occur with intravesical therapies?
Yeah, so I think it starts early, before they even start with counseling, really telling them, that these are the things you can potentially expect. And especially in an older male with a prostate who may have some underlying already bladder dysfunction, it's more likely that they do experience things like this. And then if they're really struggling with it, I also tell them, hey, this usually means that it's working. And patients seem to like that. When they have quite a significant response, it usually means the immune response is acting accordingly. So it helps a little bit with just managing the anxiety of the medicine hurting. But on top of that, I mean, there's so many treatments that you can do. I think, obviously you can stop or delay therapy, but trying to instead treat the symptoms themselves with medications. Encouraging hydration is super important. So not around the time of some installations, you actually want patients to be dehydrated going into like a Gemdosi installation, for example, but afterward, hydrating significantly, avoiding bladder irritants that can concomitantly exacerbate these symptoms. And then, for someone like this who's trying all those things and it's not working, trying a anticholinergic or a beta-3 agonist medicine to try to calm the bladder down, perhaps relax the bladder, let it spasm less so that you can potentially tolerate the medicine longer. If someone's having a lot of burning, peridium can be helpful. Certainly checking for UTI. UTI can exacerbate all of this, and with the catheter placement and installation of these medicines, UTI is a common side effect. You can try anti-inflammatory medicine, and then if it's really bad, you can even think about like bladder installations, like with like Marcaine and heparin, as like an adjuvant kind of help. But lots of multimodal things you can do. I've also had some success. Some patients that have BCG, particularly in multiple installations, can have a lot of chronic pelvic pain, can have that kind of build up over time, urgency, frequency. Pelvic floor physical therapy is a really nice go-to for them as well to do concomitantly. So trying to treat each, symptom like we would otherwise outside of the cancer.
Do the symptoms ever cause you, and actually a question just came up in the chat about this, to reduce the dose in an effort to increase tolerability?
Yeah, absolutely. I think reducing to a third dosing is a great kind of first line trial.
Dr. Black just mentioned that he doesn't routinely check UAs before an installation. Do you check UAs or ever think about kind of holidays, like a treatment holiday mid-induction?
Yeah, we check UAs before installation, just dips in the clinic, and with symptoms or with even nitrates, we're a little hesitant about giving it unless it's someone that has nitrate positive urine for peridium reasons, or that's chronically done. But yeah, we are checking beforehand. I don't think you have to. I think symptoms say a lot. I have some patients that are chronically infected, and so I'll give them an antibiotic kind of around the time when they're getting their installation to try to prevent the fact from them delaying the installation because they have a UTI, or at least they have colonization if they have no symptoms. But we do check routinely.
Dr. Black, you mentioned not checking in UA. Do you essentially only hold for gross hematuria, or are there other symptoms that you hold for?
Yeah, I think, sorry, I think, a lot of patients have UTIs, and I think that's readily apparent, and they get tested for that, and we hold if they have a UTI, but not for the usual irritative symptoms. And then I'd hold for gross hematuria. I think that checking the UA, I would, devil's advocate, I would say that it actually leads to holding treatment when we shouldn't, because of misinterpretation or whatever. I don't want to say that Pauline would misinterpret anything, but just in general, if it's left up to nursing staff, for example, they'll often hold because of something, and it doesn't really make sense. So we just don't check at all. But of course, we will survey for infection for patients acting infected. Yeah, the other thing I would say is that I've had good experience in the patients, especially in second line and beyond, using a BNO suppository during treatment. Although they're not BNO here anymore, they're BNM, belladonna and morphine. But that can get a patient through the severe irritative symptoms, and the inability to hold the drug for the full 1 hour, or whatever the time period might be.
That's also something that's been susceptible to some periodic shortages as well, at least south of the border. I'm not sure how it's been.
Same here, yeah.
Yeah.
We miss that medicine a lot.
So let's say we have an 81-year-old woman who receives intravesical nadofaragene for BCG unresponsive CIS. Dr. Black, what should urologists know? You alluded to this when you were going over the data on cretostimogene, but what should urologists know about the commonly seen adverse events with the adenoviral vectors, or even some of the newer medications that you mentioned? But the two that we kind of highlighted earlier, nadofaragene and cretostimogene, just because these have a slightly different mechanism of action than some of the medications to which urologists may be accustomed.
Yeah, I think for the most part, I think urologists are going to find this very easy, and I know some are already doing nadofaragene, of course, because it's mostly just local bladder irritation, so dysuria, frequency, urgency, bladder spasms, that type of thing. I think with nadofaragene, you can get, I sort of describe it as flu-like symptoms. So you can get a little bit of fever, chills, that type of thing. cretostimogene, as I highlighted it because it is interesting, and maybe it's, well, yeah, I don't want to say anything about trial design, but it is interesting that they did a trial with 85 patients and there was not one single grade 3 or greater adverse event. So that speaks to the particular tolerability of that agent, and it doesn't look like there's as much of this sort of fever. On the chart here, it says pyrexia and fatigue with that as there is with nadofaragene. The N803, I have troubles getting used to the name nogopadenkin, but it is given with BCG, so it has all the side effects of BCG. So it actually, if you look at the numbers like this from the QUILT trial, then they look worse just because the BCG adds to the toxicity. But it's mostly, this would be similar to giving gem-dosi. So it's mostly bladder toxicity, I think, that the urologist has to be thinking about.
It did seem to me that and maybe this was some attenuating effect of the IL-15 analog, that the side effect profile was a little lower than what we expect with induction BCG in the QUILT trial, but still, I mean, same side effects.
Yeah.
Do you have much experience with the side effects of the pretzel of TAR 200?
I have no direct experience. I've sat around a lot of tables talking about it, but maybe you do have experience. But I think there is some concern that patients, notice the irritation of having something in their bladder over many weeks. And we also have to consider with TAR 200 the repeat cystoscopy. So it's a cystoscopy every 3 weeks to pull out the old one and then deploy the new one over the catheter. And the things that may seem unlikely seem to then become likely when you have something like this. So, it's a very expensive, piece of equipment device. And if you have to take it out, of course, you've lost all efficacy just, at that point. And if you can't get the catheter in, so it comes, you load it through a special catheter. And if you can't get that catheter in, you've committed to the cost of that device without the patient getting benefit. But they're working on modifications to help improve with some of those barriers.
Well, thank you, everyone. We have time for questions from attendees. With respect to some of the questions that we have discussed, I think we've answered a lot of them in the chat. I'm going to posit this one to Dr. Black, given his role with the NCI in thinking at a higher level about clinical trials, and would love your thoughts, Dr. Koshkin, as well. But, a lot of the trials that we've seen for BCG unresponsive disease have been single-arm trials. Do you have any thoughts about what would be a quote unquote standard of care comparator? You mentioned that we need more head-to-head. Do you have any thoughts about what would be a standard of care comparator for BCG unresponsive disease?
Lots of thoughts. So I think we did through the NCI and the Bladder Cancer Task Force, we did what's called a clinical trials planning meeting. It's now 2 years ago. And it was all around sort of the next trial design. We have all these single arm trials and BCG unresponsive CIS. What do we do next? How do we move the field forward? And it was all about comparison trials. And so a big question was, what would be your comparison? What's the standard of care in this disease setting? And the reason why we have single arm trials is because there was no real standard beforehand other than cystectomy, and you can't feasibly randomize to cystectomy. In principle, we could now pick any one of the FDA approved agents and say, one of them is a standard. We had pembrolizumab first. And so it was talked about for a while, is pembrolizumab now the standard for BCG not unresponsive non-muscle invasive disease? And I think there was a lot of hesitation to accept that because of relative toxicity and relatively modest benefit. And so when we did the clinical trials planning meeting, that Pembro was the only one approved, but the general consensus was that the combination gem-dosi was actually what was being used in Canada and the US as the de facto standard. And it's not FDA approved, but the FDA was very clear that it doesn't have to be FDA approved if the community of experts, whatever, considers it the standard. So gemdosi would be an option, or I think any one of the novel agents could be an option in a comparative trial.
Yeah. Well, actually, can I ask a follow-up question on that maybe? Is it the case that the FDA will now mandate more like the conventional randomized phase 3 and any approvals going forward will have to do this, or
they've been pretty clear they're not going to change the recommendation. They recognize that we, the field, the urologists and the medical oncologists, everybody in the field think that it's time to do comparative trials, and they welcome that. There's a lot of this activity around BCG unresponsive disease arose from a conversation between AUA, SUO, and the FDA, and it led to a guidance document which was published as draft form, I think first in 2016, and then finally in 2018. There's a new draft out there now, 2024, and they haven't changed it. They haven't said, okay, now you have to do randomized controlled trials.
Dr. Philippou, are you using much intravesical mitomycin, not just in sort of the post-TURBT adjuvant setting, but as an induction or maintenance therapy? Are you using it very much?
I'm not very much. I feel like mitomycin has quite a side effect profile, at least comparatively, compared to gemcitabine, for example. It seems to be at least comparatively not as well tolerated, but it's certainly available and an option. And but I don't tend to use it very much. No. What about you guys?
Dr. Black?
No, I mean, I think I agree 100%. And it's more expensive, which somebody just wrote. It's for completely artificial reasons. It's a lot more expensive. The only time I would think of using it, I don't think I've done it in a while, is if I have a patient with intermediate risk. So just these recurrent low-grade TA tumors, and I've run out of things to do, I might consider mitomycin.
Yeah. I mean, I think we sometimes underrepresent the burden of that trajectory on patients, because it does mean extra resections, possibly extra anesthetics. So even if it's sort of recurrent low-grade tumors that we know have a very low risk of adverse cancer-specific events, they are burdensome to the patient. And so I think thinking about mitomycin or gemcitabine in that circumstance can be really helpful. There was a question earlier, and I know you gave an answer, Dr. Black, but I wanted to talk briefly about radiation therapy for non-muscle invasive bladder cancer. So the question related more to like an older, frail patient. But Dr. Philippou, are you referring any patients for radiation therapy for non-muscle invasive bladder cancer?
I'm not, but not for non-muscle invasive. For muscle invasive, certainly, but not for non-muscle unless there's a high concern that it is a muscle invasive that's just been undersampled. Or
Dr. Black?
I mean, I don't refer a lot of patients for it, but I think it's something to consider. There's not a lot of data, and I think that's why none of us are excited about it. But if you have a solitary high-grade T1 without a lot of CIS, it kind of makes sense that it should be like muscle invasive disease. If you're otherwise thinking cystectomy, there's some single center retrospective data from Germany that shows good results when given with radiotizing chemo. And then there's the recent RTOG trial. I'm blanking on the number, but 06 something or other. And it was a single arm trial in patients with high grade T1 where it was deemed necessary that they have cystectomy, but they had radiation instead. And so some of them were BCG unresponsive, some of them were BCG exposed, some of them, I think they'd all had something, but so it wasn't a uniform patient population. And the control in the bladder seemed okay, but a fair number of patients ended up with metastasis and died of bladder cancer. So I think that the NRG, which is the the more current name for RTOG, are trying to launch a trial that builds on that in T1 disease, a randomized trial. And so I think, I think we need more data, but ultimately, especially in the frail patient who's not good for cystectomy, we should consider it.
Yeah. And I believe it's actually included as one of the options in NCCN guidelines. But again, not based on very, very strong data, as Peter mentioned.
Yeah. And, there were a couple of questions about kind of old, frail patients or patients unsuitable for, anesthesia and other interventions. And I would just, remind folks that surveillance sometimes is a reasonable option for non-muscle invasive bladder cancer. If you think their competing comorbidities are substantial enough that an anesthetic is too high risk, Dr. Philippou mentioned considering spinal anesthesia, but also sometimes nothing is okay too. It's hard, but sometimes it's okay too. There's a question, and I'm interpreting this as sort of an ethical question, but is it appropriate to suggest intermediate risk patients enter into a clinical trial of a new therapy to lower their recurrence rate? Dr. Black, do you have any thoughts about that?
I don't understand why it wouldn't be appropriate.
It's recommended in most guidelines that intermediate risk patients consider some induction therapy.
So is it appropriate? So there's a prominent trial that is comparing, I guess the question, the surveillance is compared. Okay, I got you. There's one trial that is ongoing in the intermediate risk population that compares drug versus nothing surveillance. And if the patient recurs, they can cross over and get the drug. I think it's reasonable. First of all, a lot of these patients don't need anything. We do tend to overtreat. I think the risk of progression is very low. So the patients aren't going to have a bad outcome. And either way, they potentially get access to a novel drug. What I think from a trial design point of view, I'm not sure how successful it's going to be, because we as urologists will only put the lowest risk patients on the trial where we think that it doesn't matter that the control arm is surveillance. If you have a patient, if we think of high grade TA now as part of the intermediate risk, are we going to put those patients in that trial? Maybe not. We might put them on, something else. So I don't have any ethical concerns with it, but it may undermine what the sponsor wants to do.
I think most of the discussion around that study was that most of us would focus on our low-grade intermediate risk patients and not enroll TA high-grade patients. But yeah, I think it's perfect. There was a question on this, and I apologize, I should have preempted this, but Dr. Koshkin, what would you do for a patient with refractory diarrhea getting pembrolizumab? What would be your go-to treatment for that?
Yeah, so that patient has basically grade 3 diarrhea or grade 3 colitis. So that would indicate treatment with systemic steroids. I would start prednisone, 1 mg per kg, and basically treat until improvement, and then taper probably pretty slowly. Oftentimes in a patient like that, we would also refer for endoscopy or colonoscopy, basically to confirm. But when it's clinically apparent that it's a checkpoint inhibitor induced colitis, you don't always have to do that. In situations where there are some cases, unfortunately, which are refractory to steroids or to prednisone alone, then you have to go to other immunosuppressants. And in that situation, I usually would involve my colleagues probably in GI to help with that as well.
Thank you very much. I want to thank our panelists again, Drs. Black, Philippou, and Koshkin, for their participation and great insights. So thank you, everyone. This concludes our program today. You may now go to AUA University to claim your CME credit for this educational activity. Thank you so much for joining us, and enjoy the rest of your evening, everyone.